Hi, welcome back to the Balanced Health Information Podcast. I have my guest speaker here, Erin Moss, and we're going to be getting into different HIM professions out there. I know a lot of us are just familiar with just us pushing records, picking up records, just storing them in HIM, but it has become more widespread, and it's actually a career that some of you guys may not thought you wanted to get into, and you fall into it like me. I thought I was going to be a doctor, and I ended up getting into HIM because I had a cousin who was a nurse that did informatics, and she said, you need to get a profession that's going to get you a job right away. And then I got myself into HIM, and I'm never turning back. It's a field that I love, I'm passionate about, and I know that Erin's passionate about that. She stayed tethered to us for all these years. So welcome back, everyone. Let's get into it.
Hey everyone, how's everybody? So this is an exciting topic for me because I gotta say HIM's been very kind to me as far as a career path. It's got so many different levels and different, I would say, legs. And you know, like Samantha, I got into it by accident as well. I remember just needing a job, working as a clerk, and really not really understanding the full dynamics of what medical records was back then. But there's, for the future, professionals, there's so much to get into now. It's not just about pushing paper or collecting charts. It's so much of the skill sets that warrant you to go far. So Samantha, we and I want to talk about the different divisions within HIM that people can explore as far as a career path.
Yeah. So I know, as also being a professor, that's my other, I moonlight as a professor for a few colleges in health information technology programs, and then of course with the coding program. So I know a lot of us are familiar with coding, but we're not familiar with the other aspects of HIM, such as the chart completion process, which is basically the beginning of the process of ensuring that we have all the documents from not only the electronic environment, but also as well as the paper portion. Yes, there are EMRs, and majority of those documentation for a patient is in the EMR, but there are cases where there's paper that does need to be retrieved from the units, where there could be, there could have been a downtime, or there could have been the signature pads weren't working at the time to receive consent from the patients to give general care, or to have a operation or procedure or anesthesia administered to them. So we have that. We have, so with the chart completion team, those that are retrieving those charts, they can be called chart retrieval, they can be called scanning, or they could be called chart completion. Many names for it, where they're scanning those documents into the EMR. And then there's the process of indexing. If you have an EMR system that's working properly and you have the forms with the barcode on there, the barcode will then pick up those document types, giving it the name that is appropriate, such as consent, general consent, consent for procedure, discharge summary, physician. And with the EMR system, it has made it so many personalized document types that, progress notes medicine, progress notes surgery, that exists out there. But that you would need an individual, because yes, we have computers out there, but you still need a body ensuring that that information is accurate. So it is appropriate when you're reviewing the EMR system.
Right. And that's where your QA comes in, right? Because those frontline people who are looking at those documents, they have to be keen on what they're looking at, right? For instance, there was a Joint Commission survey, and I would say the one that they got, the thing that it got in trouble with was the consent for transfusion. Yes. They didn't see it on chart. And for some reason, of course, HIM got blamed for it not to be there. But what it was it was not signed off in their nursing department, because nursing is truly responsible for that, and that needs a signature. So that is a scanned document that wasn't scanned. They did eventually find it, but again, the responsibility to audit something that's missing is really kind of, I would say, inter responsible, if that's a
Mhm.
word. But always HIM always ends
Always
up being
HIM.
responsible, right? Yeah,
That,
but
that
that's
leads
your
up,
your QA.
yeah,
Um,
that leads up to the other title that you can have in HIM, which is a chart analysis. Those are the individuals that are doing the QA process, reviewing the chart, ensuring that it's complete for any missing documentation. Also, the in the chart analysis process, this is where we are adding deficiencies, which is an alert that will go out to the provider. So with EMR system, it has made it easy where you can just put the deficiency in, put in your choose the document type, choose the physician, the resident, the medical student, and then an alert will go out to their system. So when they log into the EMR, it's usually supposed to be a pop-up. I know some facilities turn it off, but it's supposed to be a pop-up that appears that says missing document, missing signature, CDI physician query, or missing orders, any of that information that pops up. And then the provider will then have to click in order to even proceed to even admit patients or to document. They will have to click and address those deficiencies.
right.
Oftentimes they're able to bypass it. I know that in some facilities they do make it a hard stop, and
Right.
others they do make it bypass with a comment, I will review later, or etc. And later never comes oftentimes.
Right.
So there's that chart analysis process, which is also where they have to contact the providers. I know with some systems, technology systems, there is a letter that frequently goes out, probably a week after the deficiency, 10 weeks, depending if the process works. I know for me, I've never seen this letter work properly in our workflow, and which would have been beneficial. So we still have to do the phone calls, hard calls,
Mm-hmm.
sending the emails, even popping up on visits, or even showing up in rounds. I think that's effective. Hey, we're here. You have missing signatures. You have a missing document. Can you please complete it? So I know I've had my team often do that. And I know some of you out there is like, why would I want to do that? But it's not bad. Trust me. It is a great job to have, and I find it fascinating. I've known a lot of people that if you're interested in investigating, chart analysis is for you, because there is
Yeah.
an investigation process there.
And remember, those numbers get reported to the state.
They do get reported to the state.
Right, so it has to be accurate. You have to have really a good eye for accuracy, definitely.
Definitely detail orientated, and also you need to understand medical terminologies and what is needed, because I've often seen individuals get a little bit tied up with, oh, the H&P is not present, and it can. So yes, the standard is there should be a document type called H&P, or general admission, OB admission note, some kind of admission note that exists out there.
Right.
But oftentimes, if the provider or the resident or the NP, could be any clinician at that, can write it in a progress note with all the elements that is supposed to be in an H&P, the history and physical, the plan, the assessment, etc., of the patient. So you also have to have an understanding of what are the elements that the document needs to be in order to be a chart completion. You cannot just you just basically cannot work blindly and just think that the process is always going to be the same with each provider and each service. You're going to encounter some people do things differently. And yes, there should be a standardization, but you need to be aware of the different terms that exist out there for certain documents.
Absolutely.
So another profession that's out there is also ROI, which we call for short, and that's not return on investments. I wish I would love a return on my investment, but it is what we call release of information. It also could be called correspondence unit, and I know Erin does not like this area.
It's too hard. It's always a problem area. It's too hard.
And I think a lot of vendors recognize that, so they created their own ROI companies where you'll see facilities actually outsource this to vendors because it's the difficulties, the regulations, HIPAA. There's a lot that you have to pay attention that you are not violating, because the facility can be dinged on this, and you could potentially hurt your patients by inappropriately releasing records. But some of them are in-house, and I gotta say, I actually enjoy ROI. We have it. It's more hybrid. I've seen it more hybrid, where we have the vendor do a portion, such as probably patient requests or the law firm requests, but then we will handle the subpoenas, the court orders, and stuff like that. So it's depending on the workflow. But the release information, I think, done properly, can flow very efficiently. And I think it can be a less daunting process once the process is clear and the procedures,
Right.
which is a great purpose.
It's I always call it the problem area. You have, when patients are requesting their records, I want it now.
I want it now.
Yeah. You don't know what the story is behind, those requests. When you want to be not only compliant, but you want to be compassionate too. Especially when there's an urgency for a patient to request their records. But we all have to abide by the rules.
Yes. And of course, there's also in the process, we have about 7 to 10 business days. It could be 7 to 14 days to respond to the records. I know I've got overachievers. I don't know if you ever work with overachievers, but I've got overachievers that the patient comes in, I want to give them their record now because they want it now. But then now you're setting the expectation that every time a patient comes in, they're going to want their records immediately. And that's not how it works. Sometimes it could be a 1-day stay, but then it could be a stay that's actually, 100 days. It's going to take a little bit longer to compile. Not only that, but then, as we said earlier, with the chart completion, they're applying deficiencies. Sometimes those records are not ready because the provider has not completed their review. And if it's a teaching hospital, most likely a medical student has document, and an attending needs to review those records to ensure that the information is accurate in there.
Right. Exactly. Again, back to, the medical legal responsibility of us being a record keeper and a gatekeeper of a record.
Yeah, the data stewardships. So far we've discussed under the umbrella of chart completion, we've discussed scanning, chart analysis, ROI, and now we have just
identity management.
We have identity management. With identity management, it's been a new baby that has emerged in HIM field, where you're dealing with the merging of cases that were basically duplicate cases that were inaccurately or erroneously put into the system. And it could be numerous reasons. It could be that the patient was not clear in their name, or if they visit the facility prior.
Right. So let me tell you a funny story about identity management. So I would say in the early mid 80s, my first job was being someone they call the Diebold. For those who remember those big machines, they were gigantic index card machine. Literally thousands of index cards in this big gigantic Rolodex that we were able to manually maintain to see if the patient was here before. It was a 24-hour, 7-day-a-week operation. The emergency room or the registration in the clinics would call that number for you to check to see if Samantha Lugine was here before. And you would go by an alphabet, of course, process where it was not like a terminal digit, but we would do it by, of course, your last name and your first name. But again, that mistakes happen. You issue a number to Samantha, to Sam, to Sammy.
Or even women that are married and the last name has changed, or it's hyphen.
Right. So a lot of mistakes on the on the manual process, but it's the same that can happen on an EMR when you're registering, right? Whatever name they feel like giving you that day, that's the name that you're going to register, and you see in the system that it doesn't exist. So here you have a duplicate and don't even know it. But that was I'll never forget, that was one of the craziest jobs I had, but I didn't realize back at that time that that was important.
That was important.
Yeah. And then, like you said, there's a whole big explosion in that field, where you have companies who are really thriving in that business. Who
Yeah.
knew?
I know. So when you said 24 hours, do you mean somebody had to work? The department was open 24 hours? Oh my gosh, I
24/7.
could not see myself being.
I was the midnight to 8 clerk.
Oh my gosh.
I was the midnight to 8 clerk. Yes. I remember that. And I used to get stuck on doubles when somebody calls in, almost like you were a nurse. It was crazy.
Oh wow.
You had to man that. And then if you went to take a break, you had to call the ER, issue them a group of numbers, about 5 or 6 numbers, while you take your break. And then you come back and you call them and say, what numbers did you use?
Oh my gosh. Okay.
Uh-huh.
So no, the HIM department are no longer open 24/7.
I know. Thank God.
And oftentimes there's not even weekends jobs. I know some people do prefer to work the evening and overnights, but this may not be the department for you. But those there's no weekends. We don't work holidays. So it has changed. And oftentimes it's like 8 to 4 or 9 to 5 hours, really.
Mhm.
So identity management is another that emerged, and then of course we go into the field that a lot of individuals love, because you can be remote, and I know some HIM departments are hybrid, but coding is a job that I would advise anybody. If you of course need to know medical terminologies, you have to be into pharmacology, anatomy and physiology is important. But once you get into it, and especially if you're working for a facility that has a certain specialty, such as the gerontology population, or dealing with the OB medicine, etc., the coding becomes pretty much redundant. Really, it's just like second nature to you. But I think coding is a great profession for anyone to get into, for working parents, for anyone. This is where it's really driving, and coding actually is brings in a good amount of revenue for the facility.
Absolutely.
That a lot of facilities, unions, have invested in ensuring that they're investing and in and training, and working with colleges and universities to get their employees coded certified.
Right.
So you can get your CPC. You also you need to be certified. I want to make sure I put that out there. With all the other professions, you don't need to be certified. I would love to get to work with schools to ensure that those who are working as an HIM representative do get their RHIT or some kind of certification, because I think it's beneficial. It has worked wonders for coding. So with coding, you can get your CPC from the AAPC, and then with and I'm not familiar with all the coding certifications you can get with AAPC. I'm more of an AHIMA member, so I'm more familiar with AHIMA. With AHIMA, you can get your CCA, your Certified Coding Associate. You can also get your CCS, your Certified Coding Specialist. And then there's also the is it the CCSP, the Coding Certified Specialist hyphen physician, working for a physician office.
Oh yeah, for the pro fee side. Yeah.
Yes, the pro fee side. And then of course AHIMA does have certifications for CDI. I know some universities such as NYU has the program along with the certification after you have completed the program successfully, and then of course completed the exam. So the coding profession is something that I would advise anyone to get into, and it also would be good if you want to be a director, because having that coding knowledge does make it easier to run a department and actually speak to the process, such as DRGs and revenue cycle.
Right. Yeah. I've encouraged quite a bit of staff and team members into exploring. I mean, listen, being a coder in an HIM or medical record department back then was like they were the elite. It was like
It still kind of looks look as that.
Right. Coders were always looked at as the bar has been raised, right? That people strive to go into coding. And back then, years ago, there wasn't a formal training. There was a grandfathering into the profession. That if you got on the job training, you were lucky. I was at one of the very first formal instructing schools at Downstate.
Oh wow.
Yeah,
Oh,
at
I
SUNY
worked at Downstate.
Downstate.
Any of my students work there.
1986 was one of the first formal coding training schools. And Dr. Isaac Toper was the dean at the time, and I know that some of my colleagues remember him well. But you did not get formal training back in the days. It was always on the job. So the best thing always is to go to a formal training program, as Samantha has suggested, and maybe even go to an advanced degree to get the RHIT, and so on and so forth. But a DRG validation is an advanced coder, who's very key in that, and that's another step, above a coder. Coders can break out between being an outpatient specialist or an inpatient
Yes.
specialist.
ED, yeah, all of those good stuff.
Yeah.
I know a lot of people, they enjoy the outpatient more than the inpatient.
Hmm.
Some people find it more difficult to do either or. Sometimes it's I prefer inpatient coding because it's,
Yes.
it's simpler. So there's all those specialties.
Right.
Also, Aaron and I both work for insurance, and they used to call us the bad guys. I know it's a lot of facilities where we are. You could be uh what is the title that I'm looking for? What was your title for? You worked for Emblem Health, right? I think I worked.
No, no, no. It was a third party.
Was third
It was
party?
a third party. Yeah.
Hospital review analysis. That's
Hmm.
another profession in HIM. I was a hospital review analysis where we were reviewing the medical records from a healthcare facility,
Hmm.
for that insurance company. And we would then pull a code and say, well, there's not sufficient amount of documentation proving that this patient had this kind of diagnosis. So we're going to pull this code and we want you to reimburse us for this. So, there's that profession. And then the opposite side of that is actually in the hospital end would
Hmm.
be the DRG validator or appeals coordinator, which then will appeal those cases and provide the supporting documentation that the services rendered is accurate and we code it appropriately.
Yeah, and I have to say to you that has now become the core of HIM. So most organizations now split between what we call operations. So we just discussed all of those career passing operations, ROI scanning, deficiency tracking, IM, and then you have revenue cycle side that's only focused on the reimbursement, and the revenue cycle realm, of these healthcare organizations. With even that, it goes even further before you hit a director level. It's also auditing.
Mhm.
And most of the time that's coincides with ROI, because they're the ones who are releasing the information to
Yes.
the requesters or the auditors, whether it's a state auditor, whether it's a payer audit, any kind of regulatory request, risk management. All of
Yes.
those are relevant to a collaboration between an operations and a rev cycle side.
So now we're circling back to Rev Cycle, which is another profession in HIM. I know a lot of larger networks were able to split from HIM operations, CDI coding, and then there's revenue cycle that HIM would be reporting to. And with that, you still need to have a background in, of course, knowledge on coding, and then of course the operations side of HIM.
Hmm.
So revenue cycle is another profession that you can get into for a larger network, and it can also be a remote position. I know a lot of individuals that have shifted from the hospital setting to work in more of a remote environment that will allow them to just basically audit and review and ensure that what's holding up our high dollar cases, what documents are deficient that are missing, which is basically putting our cases on hold. is there any on the back end, any kind of configuration where we have alerts? This code cannot be associated with this kind of age group or this kind of gender, and all that. Any of those coding edits out there?
Yeah. But as a whole, it becomes really key that the interconnection of each of those areas, it's almost a domino effect, right?
Hmm.
You can't really code a chart unless the analyst reviewed the chart, right?
Exactly.
And you can't uh, really would say be able to do deficiency tracking with a
Without
chart
the
unless you have identity management taking out that dupe. So it's
exactly.
all interrelated.
You can't release a record unless you know the chart is completely deficient free
Mhm.
and it's completely scanned in. And yeah, you can't. So everything is all intertwined, and we basically have to work as a team unit. You have to be an advocate
Yep.
for the teamwork concept in order for the HIM to flow properly. It's not just in the clinical world, but also in our world. We have to ensure that, like Aaron was saying, it's a domino effect. You do not want to have in the front end there was something missing. It's like a Jenga game, basically. You move one block, everything will fall apart, and that's not what you want. So you want to ensure that everything is seamless, and everyone needs to understand each person's job and workflow. I think it's always
Oh
important
yeah.
to have what was horizontal job description, understanding across the board. It's like what was popping in my head is an assembly line, but it's kind of like put the block on the assembly line. You put all the attachments at the end to box it
Yeah.
up and then send it out. That's basically it. You're picking up the chart, putting it in together, making sure all the scan and the electronic are complete. You want to analyze the chart. You want to be able to release. So now there's different arrows and avenues you can go. Releasing the record, coding the record, and oftentimes, releasing coding and just yeah, that's basically it.
But Samantha, remember, well, even where you used to work, your department was set up that way that it was assembly
It wasn't
lines.
something like that's
Yeah,
probably why my mind is like
yeah,
back to
yeah,
that.
and that's how most organizations set themselves up. It was this part of the department was this part, and it literally was a physical movement of these charts.
Yeah, literally was.
Yep.
I don't miss it, but I do refer back to that workflow process sometimes
Mhm,
on how smooth it ran. I mean,
mhm,
yeah, we did have our issues like loose
mhm.
paper, because you could have that in the electronic world called chartless documents, and that's all part of identity management. Can iron that out,
Right.
but for the most part, it did run smoothly for a paper environment. So
Mhm,
I'm proud of that in that
mhm.
part. So I always I use that as a reference point and how I want my future departments to move, and
Right.
also to give guidance to any prospective HIM professionals out there that
Mhm.
need more of a direction. So I always like to refer back to that.
Right. Right. It's now become a very respected, I would say, realm of the healthcare organization. It wasn't. We were the basement rats. It was paper pushers. It was all of that. But now we are regarded highly as part of a key partner in the healthcare organization. So we've arrived, I
We
believe.
have arrived. So this concludes our basically our job references. No, is that the word I want to use? No, our jobs that exist in the HIM
Yeah.
field. And
Mhm.
of course, you can always go to HEMA.org. They have a salary snapshot shot,
I think they have a roadmap too.
and they have a roadmap of different professions such as informatics. There's a wide range of professions, data analytics that you can go into, that we haven't even touched on, but we can
Right.
always do a part two, part three. And
Mhm.
if you guys have any suggestions, please follow me on TikTok or Instagram. Put your suggestions, and we can definitely do a live and have a discussion on different professions that are out there. So yeah, thank you, Erin, for being with us. Always a pleasure to have you as a guest. I
Thank
hope to
you.
have you again in the future.
Goodbye, everybody.